My name is Yongendayk, and I am a psychiatrist, a psychotherapist, and a psychotrauma therapist at ARC National Psychotrauma Center in the Netherlands. And I will educate you in NET in several short workshops. I introduced NET in the Netherlands and developed it with certified trainings and supervision. And I wrote several publications about narrative exposure therapy. The NET training schedule consists of several modules I developed for you. And first, we start with a global introduction on NET, so you can learn what is NET all about. Second, we go to some theoretical backgrounds on NET, and then we are discussing the steps we do in the narrative exposure therapy, like creating the lifeline, doing the narrative exposure techniques, and also creating the document and ending the therapy. Also, we will discuss some complicating factors for NET, like dissociation, and also I will tell you something about online NET, and NET for children will also be discussed in this workshop. After the workshop, of course, you need good supervision to conduct the therapy on your own, but that we will discuss later on. Now, first, the indication for NET is PTSD, post-traumatic stress disorder. And there must always be a traumatic event before PTSD, and the events are defined in different ways in the ICD-11 or the DSM-5, but in general, there must be an exposure to an event or situation of an extremely threatening or horrific nature, like disasters, combat, serious accidents, torture, sexual violence, terrorism, assault, etc., but also witnessing these traumatic events can be traumatic in this definition, and also in the DSM-5 definition, which is a bit more strict than the ICD-11. There are, in fact, 3 situations where you can, which you can define as traumatic, that is exposed to death or threatened death, exposed to actual or threatened serious injury, or exposed to actual or threatened sexual violence. But this is, of course, a more general theory about PTSD. Then, after that, there must, of course, be symptoms. The symptoms of PTSD are intrusions, or better, symptoms of re-experiencing, we call it. These are recollections or automatically activated memories of past events. Can be recollections, but also can be nightmares, flashbacks, or extreme distress, but also always associated with a traumatic event. Next, patients are trying to avoid these disturbing recollections. Of course, you can imagine they suppress them or try to think about other things, or avoid talking about it, or, for instance, looking at television can be avoided because they see situations like war situations on television which they experienced in the past. Sometimes they are also afraid to go to public transport or cinemas or other places where there are a lot of people, and or visiting friends. Please ask your patients about these avoidance symptoms, because they can be hidden behind the intrusion symptoms, which are often more vivid and more dominant. And also because avoidance symptoms are often a way of life for the patients, and they don't tell about it. They are used to it. It's the normal way of doing things in life. Then in DSM-5 there are negative alterations in cognitions and mood. For instance, thinking it was your fault, feeling guilt, or feeling ashamed. And finally, alterations in arousal and reactivity that are associated with a traumatic event, like bodily reactions, sleeping disturbances, or also startle responses. Now, of course, the symptoms have to persist for more than a month and have to give significant impairment, functional impairment. And that is also very important, of course, because impairment is a criterion for illness. For now, it's important to differentiate two kinds of bad events, horrific events people experience. There are the psychotraumatic events. These are fear and threat-based. So, as we shall later see, there is a flight-fight reaction. There's a life threat. It produces sensory and emotional sensations, especially during exposure therapy. So these are threat-based, but they're also horrific or nasty events. They are not based on life-threatening situations, for instance, childhood neglect, bullying, ignoring, etc., etc. Often they do not give sensory sensations because there's not a flight-fight reaction during these situations, but they give more cognitive responses, for instance, during imaginary exposure. And these are less suited for narrative exposure and also less suited for narrative exposure. So these two kind of things, it's important to differentiate these. Psychotrauma is fear and threat-based.
Many people fleeing war zones have witnessed extreme and unsafe situations they would rather forget. This can lead to distressing symptoms. Some people have difficulty sleeping or wake up from bad dreams. Others feel sad most of the time or cry more easily. Some become nervous or more aggressive than usual. Some people have many headaches, problems breathing, or a pounding of the heart. For some, their thoughts go around in circles, being haunted by images and sounds of past events. Have you experienced such reactions? This can be part of the brain's response to extreme conditions. This can lead to unpleasant symptoms. Just as the skin heals after injury, the brain tries to heal itself after extreme stress. Often, these symptoms will subside with time, but sometimes they will remain and continue to impair daily life. Just like when you are injured, you can seek medical help for your problems. You are not alone. There are trained professionals who can help you. There is no quick cure, but with help, you can address your problems step by step. Go and see a doctor for advice.
Now let us start talking about narrative exposure therapy. What is NET? What are the differences with other trauma therapies you know, like EMDR or imaginary exposure? And I will give you then an overview of steps in the NET treatment. Now first, the international guidelines mention several trauma-focused therapies. That means therapies that specifically can treat PTSD. Most prominent are the here mentioned therapies, prolonged or imaginary exposure therapy, PE or IE, and cognitive behavioral therapies, CBT. But of course, also the very popular eye movement desensitization and reprocessing, or EMDR. These are mentioned in the international guidelines as very important therapies for PTSD, but also narrative exposure therapy has a good place in the guidelines. Directly after these 2-3 therapies, narrative exposure therapy is mentioned, for instance, in the APA, American Psychological Association, or in the NICE guidelines. It is good to have a choice, because less than 60% of patients recover after trauma therapy, 50-60%. Therefore, it's important to have different kinds of therapies, and as I will show you, NET, narrative exposure therapy, is different from EMDR or imaginary exposure. Why is that so? Well, prolonged exposure and also EMDR are originally developed for single trauma experiences. Of course, they can be used in also complex or multiple trauma, but they are developed originally for single trauma experiences. Second, they focus on often details of the worst traumatic event. And they are developed in Western countries. Now, to give you an idea what are the differences between EMDR and prolonged exposure, I will show you a table, and of course you can look in the slides later on to study the differences more in depth, but EMDR are short, but I will show you these two because I want to explain to you what is the difference of these therapies with narrative exposure therapy, so you can make a choice later. So EMDR are short moments of exposure. They give distracting stimuli like eye movement, and there's no homework involved. It's an isolated focus, so they focus on the traumatic events and sometimes parts, details of the traumatic events. Now, prolonged exposure is a longer lasting exposure with no distraction. The patient gets homework, extra exercises at home, in the exposure sessions, and also with prolonged exposure, it's an isolated focus, so it's focused on details of traumatic events. In EMDR, it's exposure on the worst picture now, the patient's experiences now, and in PA, it's on details of the worst memories in the past. In EMDR, it's we are stimulating associations and reflections, what comes to the mind, and PE is not distracting, not stimulating associations, but staying well in the story without avoidance. And PE gives the instructions aimed at reliving, so in the I form, tell the story in the I form, in the present tense, and with closed eyes. Okay, these two are very important therapies. But what is the matter with narrative exposure therapy? That's what we are talking about now. Narrative exposure therapy is especially for patients with multiple trauma, living in unstable living conditions in post-conflict areas. So what you can say is that NET, it's very special, is developed not in Western countries, but in post-conflict areas. First in Kosovo, later in refugee camps in Africa, and later on in several other surroundings and areas. This is very interesting for you because in post-conflict situations, NET is very well developed and investigated. Also, the patients in which NET is investigated had experienced multiple trauma, sometimes 20 times or more. So this is a very interesting aspect of this trauma therapy, and the developers of NET were German psychologists like, as you see, Schauer, Maggie Schauer, Frank Neuner and Thomas Albert, but also others, looked for a therapy that would be easy to conduct in this situation with these patients and to give enough stabilization and control and was applicable for these patients. So they developed narrative exposure therapy as a therapy which has more a lifetime perspective. It was more focused not on details of the traumatic event, but on the context and the story of the events, as we'll see later. Now, what are the basic principles of the therapy? As you can see here, it's a short-term treatment, like the other treatments I discussed. It's especially suited for patients with multiple trauma experiences. It's especially focused on the context of the trauma, not only on the details of the trauma. It's suited for all ages and in all cultures, also very important, all cultures, kind of cultures. It has a testifying or a human rights aspect, and of course it's evidence-based. At this time, there's a lot of research done on NET. Now let us look at the components and principles of narrative exposure therapy. Later I will discuss some of these components more in depth, but now we'll have an overview of NET. And the first step is visualizing the whole life course by creating a lifeline. Then imaginary exposure, but with integration of context information. So not only details, but the whole story, what happened as a whole. Also, not the worst, but all important traumatic experiences, not only details, but the whole experience in chronology of the lifeline. So you start at the beginning of life in the lifeline, you create it, and you go up to the present. Also, you give attention to the positive experiences. This is very important. As you saw, there were in the picture, there were flowers and stones, and the flowers are the positive experiences. people also have, and this is very special for NET. The reliving is in the past tense because you want to develop a chronological way of looking at life and the experiences were in the past, so you keep the past tense. There is no homework for the patient, but there is homework for the therapist. Unfortunately, the therapist is writing a testimony document. Okay, that was a short overview of narrative exposure therapy. Now, we will consider the steps we do in NET. First, of course, diagnostics. I think you learned about it earlier on. In other trainings, you can do the CAPS, it's an interview. The PCL5 is a questionnaire you can also use. And of course, your clinical impressions. Then you are sure the patient has a post-traumatic stress disorder. Of course, the CAPS is DSM-5 and the PCL also. You can also do other clinical interviews, or you can look at the ICD-11 criteria. Then you do psychoeducation. You must explain the patient about PTSD, but that is more psycho-information. Psychoeducation is discussing current complaints of the patient. So you explain the symptoms the patient experiences, and you explain the relationship of the complaints with past events. Often patients are not aware of the relationship between the current complaints and the past experiences. So you explain where the anxiety comes from, the panic, the images, the intrusions, etc., etc. Then you explain narrative exposure therapy. What's the therapy all about? And you have to test the patient's motivation, because it is important that the patient is aware it's not easy to do exposure therapy. Patients want to avoid, of course, and don't want to think about the atrocities they experienced in life, of course. So they have to be motivated to do it, and they have to understand, of course, that it's helpful to process these horrific events. And then you make an informed consent with the patient together, and then you can go on with therapy. Now, first, you do the creation of the lifeline. That's the second session. Or better, the patient creates his or her lifeline together with your help. This is an appealing and very helpful way of starting therapy. It is active, it's creative, it ensures a pleasant cooperation between patient and therapist, and a good working alliance, of course, for the coming very hard therapy. Now, the lifeline is laid on the ground with a rope or a cord representing the lifeline. And in chronological reconstruction, you do all the important life events, the positive and the negative ones. So you have flowers and stones, some candles and sticks maybe. Flowers and stones are the most important ones, and the patient can choose between them, and the symbols are placed chronologically along the lifeline. Flowers for the happy moments in life and stones for the traumatic ones. Optional are candles, which are for events with grief, and sticks for aggressive events the patient experienced. Together you lay the lifeline in one session for about 60 to 90 minutes. We will show later how you will do that. Every symbol gets a name and a year. And afterwards you make a picture, a photograph of the lifeline. You can also draw the lifeline or do both, and then you use this picture, photograph or drawing in the subsequent sessions. This is so the second session, the diagnostic psychoeducation, and then creating the lifeline. This can be very significant for patients because they oversee their lives at this moment, and that can be very confrontative. After that, in the subsequent sessions, we process the lifeline with the stones and the flowers and the periods between them. And we start at birth, and we go in chronological order to present. You see at the top digital lifeline, which is made in Word and PowerPoint. It's also possible with pictures from internet. And you see here birth. This is a stone, abuse by uncle. Then married, birth of daughter. Then abuse of husband, stone. Then a stone and a flower together, also possible for divorce because it was, of course, a negative experience, but the patient was also happy. She got rid of the husband that abused her. And then she came to treatment. And also there is a future, a picture for the future, and she fantasizes that she can create her own life finally after treatment. So this is an example of a lifeline. Interesting and important to consider is that in NET you do all important exposure traumatic events. From birth on, not only one or two, not only details, you do also the pleasant events and the periods between, as I said, in chronological order from birth to present. Okay, now an important component of NET also is, after the lifeline and the narrative exposure, which can take maybe 5 to maybe 15 sessions, of course, of narrative exposure. A written testimonial report is made by the therapist. After every session, the therapist describes the period in life which was discussed by the patients. It is an autobiographical way of writing, not the therapy. The therapy session is written down, but the facts and events in that period of life. At the end, the patient receives a document about his or her own life. All parts of the written testimony are collected together in one document with the picture of the lifeline with it. This is a very important part because most patients feel taken seriously. For the first time, there is someone who wants to listen, not only wants to listen to the story, but also writes it down. And very important, the patients get a tangible result of the therapy and can take it at home. Okay, this is about the practice of NET. Of course, NET is evidence-based. In meantime, there are studies in about 30 countries: Europe, Africa, Middle East, Asia, America, and many patients in these studies are vulnerable patients living in vulnerable circumstances. As we'll see in the next sheet, there are refugees, child soldiers, borderline patients, street children, etc., etc. As I told, it's in the guidelines, international guidelines, and in the last 3 years there are several meta-analyses published on NET, which is very special. Interesting, it has a good effect size, but especially after 3 to even 12 months follow-up. So often not immediately after treatment, but some months later. Now here you see a lot of studies done and the target groups, the patient groups. You see torture victims, early childhood, refugees, many studies, but also women with a long-lasting domestic violence, patients with mental illness, also perpetrators of repeated long-lasting violence, victims of human trafficking, etc., etc. But a lot are war-related traumas. Now, concluding, NET is an evidence-based treatment approach for PTSD, especially suited for patients with multiple trauma. It's especially for vulnerable patients living in vulnerable conditions. And an important characteristic of NET is that it gives trauma a broadened context, more than other trauma therapies, because of the lifeline with the symbols, the perspective on life as a whole, the perspective of trauma as a whole, the chronological working through the course of the lifeline, and testimony. This is, I think, why NET gives a different approach compared to the other trauma therapies. So this was, in a nutshell, a short introduction on NET. In the next webinars, I will tell you more in detail about the different parts of NET, and then we can go more in depth. The next webinar will be on the theoretical background on NET. I thank you very much for your attention. Einde van beeld.